This is the second part of the atrial rhythm interpretation presentation. Today we're going to cover the wandering atrial pacemaker, also multifocal atrial tachycardia and the difference between those, and we're also going to probably get into something I really don't like, which is SVT. We're going to talk about that a little bit. So let's go ahead and start off with the wandering atrial pacemaker. A wandering atrial pacemaker is where there are three different pacemaker locations, or you could also say three different ectopic areas that are in the atria that are all competing to try to be the primary pacemaker of the heart, basically. Usually one of these involve the SA node, and then you have two other ectopic foci somewhere in the atria up there. What's different about, or what's interesting about this wandering atrial pacer, sometimes it's also abbreviated as WAP, you might see that. What's interesting about the wandering atrial pacer is that the P wave will have at least three different morphologies. So you can imagine if you have your heart and you have your SA node up here, you have your internodal pathways and your AV node. If this is one focus that's beating and there's another ectopic focus over here and another ectopic focus over here, you're going to end up getting three different morphologies of P waves. So to have a wandering atrial pacer, you have to have at least three different. If you only have two different, clearly different P waves, then that's more of a competing atrial pacer, not really a wandering atrial pacer. So what happens is you end up with three different, just like in the other picture, you end up with three different morphologies of P waves. Now notice the QRSs and the T waves are all the same, so there's no ventricular problems. We're still only talking about atrial. So this right here, we'll pretend this is the SA node, and you have a nice picture-perfect P wave. And then you're going to have one of these other two. I'll pick the pink one here. This one starts competing right here, which gives you a clearly different morphology. And then you have this green one over here. We'll say this is the third ectopic focus, and you have a clearly different morphology that is nothing like the other two. Now there always is going to be a slight change in a normal P wave, which is perfectly normal. So if you have your first P wave that does this and your second P wave that does this, technically that could be from the exact same spot. So what we're looking for are three clearly different. So as you can see, that one is upright. This one is biphasic with an initial hump. You could also have one that's biphasic with a terminal hump, and you could also have one here that's inverted like this. You could also have an ectopic atrial which causes it to do something like this or whatever. So the point is that there are three clearly different P waves to find a wandering atrial pacer. To try to explain this a little bit better, what we have here is we have our initial pacemaker, and we'll say that this is the SA node right here. And you can see the SA node is clipping along at a normal rate just like it's supposed to. Then you have pacemaker 2 right here, and we'll say that this is a, just for fun, a right atrial ectopic focus in there. Not the SA node, but somewhere in the right atrium you now have an ectopic focus in the right atrium that's clipping along. So what you have here is its own intrinsic rate that's also going along at that time as well. And then we have pacemaker 3. Let's just say pacemaker 3 is a left atrial ectopic focus. And as you can see here, this is the green ones down here, and it's much slower of an intrinsic rate, this ectopic focus down here. Now what we want to do is I want you to look at the strip down here, because what you have up here is almost like a three-dimensional rendition of what's going on with these three pacemakers. Well, we're printing this on a two-dimensional piece of paper. We can only see what the EKG actually finds or is strong enough to put down on paper. So as you can see right here, pacemaker 2 in the right atrium, it's clipping along pretty fast. So the EKG sees this one right here, which is this right here, which is going to be this P wave. And then at the same time, these other three or these other two are still clipping along, but the EKG then sees the second one or the third ectopic focus, which then you see this one right here. So the third ectopic focus has that kind of depolarization. And as you can see here, this one right here, this one right here. So as you can see here, the machine, even though it's picking up only certain ectopic foci, they're all three trying to compete at the same time to be the primary pacemaker of the heart. But what we have here is three clear different P wave morphologies. And the easy way to identify this is if you look at this, you can say, okay, there's P wave number 1, and there's a P wave number 1, and there's a P wave number 1, and there's a P wave number 1. This is a different morphology, so that's P wave number 2, and that's P wave number 2, and that's it for that strip. And then what P waves have we not identified? Here's a third one right here, and there's a 3 right there. Now I have labeled all 3 of my P waves. Okay, so I have 1 morphology, 2 morphologies, and 3 morphologies, which would tell me that this is a morphology, this is a morphology, and this is a morphology. Some causes of a wandering atrial pacer include vagal effect of respirations on the SA node and the AV junction, drug toxicity. It could be normal in some people, and some type of atrial enlargement, usually due to increased blood return like chronic congestive heart failure or some other disease process. What are the characteristics of a wandering atrial pacer? The first thing, the rate itself is going to be less than 100 beats per minute for it to be a wandering atrial pacer. Usually when it comes to the regularity, it is usually irregular. And that's because of the competing atrial pacers that are going on. The P waves, like I said before, they will have at least three different morphologies. The P to QRS ratio, the P to QRS ratio is still going to be 1 to 1, which means they are still married. The PR interval will either be normal, it will be normal, usually, but it could also be varied. But it is still going to be a normal PR interval. The QRS width, it could be anything because this is not a ventricular problem. So let's go ahead and look at some rhythm strips right quick. As you can see down here, we have, if you just glance at the rhythm, it looks regular, but it looks like that there's some changes down here. So here's what we're going to do. We're going to go ahead and start off with the rate. So we're going to start here, and this is a 300, 150, 100, 75. So we'll say that the heart rate is an atrial rate of about 80. The ventricular is going to be about 80. Regularity, it looks regular as far as I can tell. If you have the strip in front of you, go ahead and do it with your calipers and see if it actually comes out that way. But we're going to say that the regularity is regular. It could be slightly irregular though. Now the P waves, this is what's interesting. The P waves, they are married, but we have different morphologies. So what we want to do is you want to look at these P waves and see, do we have at least three different morphologies? Well, let's look at this. This is one morphology right here. Do you see this morphology anywhere else in the rhythm strip? And the answer is no. So this right here would be considered one morphology. Now let's look at this P wave right here. Is this P wave a different morphology? Yes, it is. Do you see this morphology anywhere else? Now notice this goes up then down, this goes down then up, this goes down up, that looks inverted, that looks weird, maybe a down up, and that looks inverted. So that's definitely the only one of that one. Now remember, this one goes up down, this one goes down up. So here's your 3 right here. This is your third P wave. Do you see another P wave that looks like that one? This one might be it, but it looks pretty different to me. I can't really tell. So we're going to say no. And so we're going to go ahead and use this as a 4. So we have at least 3 different morphologies here. So different morphologies, yes. We have 3 different morphologies, so let's go ahead and continue on with our PR interval. In the PR interval, we have a good one right here. That's about 0.12. This one, 1, 2, 3, it's about 0.12 also. So we're going to, since I'm doing this quickly, I'm going to go ahead and say the PR interval is 0.12 second. The QRS complex looks nice and narrow. Look at that, really nice and narrow. So it looks like a 0.08 second. My underlying rhythm looks to be maybe a sinus rhythm, but if we say this is a sinus rhythm, we're implying that all of the P waves are coming from the SA node, being the sinoatrial node. So I can't really say that it's a sinus rhythm, but I do have at least three different P wave morphologies, so I'm not going to call this a sinus rhythm. I'm going to call this a wandering atrial pacer. Let's move on to the next one here. What is our atrial rate? We have a 300, 150, 100, 300, 150, 100. So it looks to be right about, just about 100. Actually, this one looks a little bit slower. So we'll just say 100. And this is 100. It looks irregular. The P waves are present and married, but different morphologies. The PR interval, well, let's start down here. It starts right about here, 1, 2, 3, 4.5 maybe. What is this one? Starts about here, ends about here, 1, 2, 3, 4, 5. Oh, see, that's about 0.2. So we'll just go ahead and say 0.20 second, which is on the long side of normal, but it is still normal. The QRS complex looks to be about 0.10 second. The interpretation, what is the problem that we have with the rhythm? Well, this right here, different morphologies. That's the issue. So now we have to figure out what's going on. Can we call it a sinus rhythm? You usually don't, because it implies sinus atrial node depolarization causes all this, but it doesn't look like it does. So we have different morphologies. So let's look. This is one morphology right here. Do I have this morphology anywhere else? That might be it. I'm not really sure about that. That's a different one. That's different. Let me see, that one, that one. All of these actually look different. So there's one morphology. I'm going to call this morphology number 2. Then I'm going to move over here, and I'm going to see this might be a number 2. That might be a number 2 also. So we'll just say, yeah, that's a number 2. That's a because those could actually be different pacemakers, and that looks like it. This looks like a number 3 right here, and that looks like a number 3, and that looks like a number 3. What this blue arrow is showing right here is that there is a P wave somewhere in that T wave right there. Unfortunately, we can't identify what morphology it is, so we're just going to have to leave this one be. And let me see here. This one right here looks to be actually different than the rest, so that might actually be a 4th different P wave morphology right there. So since we have 3 different morphologies, we're going to go ahead and say that this is a wandering atrial pacer. Moving on to the next one here. This is an irregular rhythm. It looks like it's a normal rate, but let's see if we can figure out how much is 300, 150, 100. This is going to be a 300, 150, 100, 75, 60. So maybe that's a 70. So we'll just average it and say it's like, what, 80? Regularity, if you just glance at it, you can tell it's irregular. P waves, all P waves are present and they are married. But they're different morphologies. My PR interval looks to be, that looks to be about 0.16. That looks to be about 0.16. Yep, 0.16 second. The QRS complexes look nice and narrow. They look to be about 0.08 second. So what is the problem with our interpretation right here? We have the different morphologies up here. So I'm going to look down here. This is one morphology. Do I see that morphology at all? And that might be a 1 right there. We have a different morphology right here. Can't really tell. This looks like a third morphology right here. That's a 3 right there. This might be a 4. So it looks like we have more than 3, or we have at least 3 different morphologies to make this a wandering atrial pacer. On this one right here, let me see here, 300, 150, 175. So we'll say this is like a heart rate of 90. Regularity, it looks regular, but take your calipers and check, because this might actually be an irregular rhythm, but I don't have calipers on me so to do this on this digitally, so I'm going to go ahead and say it's regular. If it's irregular though, please put irregular. P waves, do we have P waves that are married to the QRSs? Yes, we do. Present and married. Different morphologies. The PR interval seems to be, this is kind of hard to tell, but that looks to be about a 0.12 right there. From here to here looks to be about a 0.12. So I'm going to go with 0.12 second. The QRS complex almost looks a little bit wide. No, actually it looks pretty good right here. So I'm going to go ahead and say 0.10 second. What is the problem? Different morphologies. So now we have to interpret this based on the different morphologies. So we have one P wave right here. That looks like a 1. That might be a 1. We'll come back to that one. That looks like a different one. That's a 2. Do I see another 2 over here? Nope. That looks like a 3. That looks like a 4. That looks like a 4. So we have 3 or more different morphologies. Wandering atrial pacer. Start off with our atrial rate. We have a 300, 150, 175. That looks to be about 60. 300, that's a 150. 300, 150, 175, 60. So 60 to 100, we'll go ahead and just average it and maybe say 80. Regularity, if you just glance at it, you can tell it's irregular. The P wave is present and married. Different morphologies. PR interval starts here, ends here. Let me see, 1, 2, 3, 4. So that's 0.16. That looks to be about 0.16. Here to here, that's about 1, 2, 3, 4, 0.16. So the QRS complex looks almost a little bit wide. So we're going to say 0.12 second. I really wish I had some calipers to do this. It would make it a lot easier. This is kind of hard for the QRS because, as you can see, it's scooping here. So you want to use something where you can see a definitive deflection And it's like this might be the only, this is the best one right here to find a definitive deflection away from the QRS complex. So the interpretation, what is the problem that we have? Definitely we have different morphologies. So now let's find out how many morphologies we have. We can have one morphology here. Do we have another one morphology that's a number 1? This might be a number 1, so we'll go with it. This right here looks to be like a number 2. That looks to be like a number 2. Not sure what that is. Not sure what that is. This might be a number 2 right here, or it could be a number 3. So I'm putting a question mark here. I know for sure that's a different morphology right there. And this, so it doesn't matter if this is a 2 or that's a third morphology. This right here, this could be a different one right here. You could have up to 4. So we know we have 3 or more. So we're going to go ahead and say this is a wandering atrial pacer. Start off with our atrial rate. Here we go. 300, 150, 100, so a little faster than that. 300, 150, that's really fast. 300, 150, 175. 300, 150, 175 here. Looks to be a little bit, so we'll just say 90. What ideally you want to do is you want to figure all these out and average them or do a range. I'm just estimating because I'm trying to speed this up a little bit. Ventricular rate, it looks like there's a P wave for every QRS, so we're going to say 90 beats per minute. Regularity, if you just glance at it, you can tell it's irregular. P waves are present and married. But different morphologies. PR intervals, let's see if we can find a PR interval here. Here to here, that looks almost like a 0.20 right there. Let me try this one right here. 1, 2, 3, 4. So maybe it's more like a 0.16. QRSs, they look really deep for a change rather than way upright. They're way deep. You'd want to do a 12 lead on this person because it is lead 2, and in lead 2 all QRSs are supposed to be primarily positive, not primarily negative. And since this is different, you'd want to do a 12 lead on this one to find out why is it different like this. But let's just continue with our rhythm interpretation here. From here to here, it looks to be about a 0.12 seconds. So we're kind of on the borderline of narrow versus wide. We'd have to do a 12 lead to confirm that. Interpretation, what problems do we have up here? We have different morphologies. So let's find out how many we have. We have one morphology here. Do I see that morphology again? That might be a 1. I'm not really sure. So we'll go ahead and say a 1. Here's a 2 right here, kind of a peaking. Do we have another peaking? It doesn't look like we do. This, I can't really tell. So I'm going to come back to this one because this is kind of buried in that downslope of the T wave. So I'm going to come over here. We have an up-down morphology. That's a 3 right there. That's an up-down. That's a 3. That looks like an up-down. That looks like a 3 also. So we have 3 different morphologies of P waves. So we're going to call it a wandering atrial pacer. Next, we're going to discuss multifocal atrial tachycardia. This is going to be really easy because if you understand what wandering atrial pacer is, then you're going to be able to understand very easily what a multifocal atrial tachycardia is. The only difference is it's faster. The heart rate is faster. That is all. So let's look at the characteristics of a multifocal atrial tachycardia here. The rate itself is going to be greater than 100 beats per minute. That is the only difference between a wandering atrial pacer and a multifocal atrial tachycardia. The regularity is going to be irregular. Normally it is considered irregular, but it could be regular as well. It could be, but so it can be either one. The P wave itself, once again, it's going to be present and married. But what are we going to have? 3 different morphologies, at least 3. The P to QRS ratio is going to be 1 to 1. Oops, that should have been down here. And married. The PR interval, normally it's going to be normal. Typically it's normal. But it could be varied. Somewhere within that 0.12 to 0.20 second. The QRS width, once again, this is not a ventricular problem, it is an atrial problem, so the QRS could be normal or wide. Some causes, emphysema exacerbation, whenever somebody has a history of emphysema and the exacerbation is just an acute exacerbation, gets a little bit worse for a little while, that kind of stuff. Congestive heart failure, mitral valve regurgitation. There is one thing that you need to remember, and this is very important, and a lot of people forget this. You need to remember that at times, multifocal atrial tachycardia can be very easily confused with atrial fibrillation. And I've had a lot of students throughout the years look at an atrial fib and try to find P waves and go, oh, this is multifocal atrial tach, when in reality it's only atrial fib. The only thing you can do is practice, practice, practice to try to make sure you can distinguish between MAT and AFib. Just remember, though, most of the time, atrial fib is atrial fib. If you have to search really hard to try to find P waves in an atrial fib, then you're probably looking for something that isn't there. So when in doubt, maybe it's more of an atrial fib. MATs are a lot more infrequent. You're going to run into a lot more AFibs than you will MATs. So let's go through some rhythms right quick. The first one here we're going to look at, you want to get your atrial rate. It's going to be pretty fast. Here's 1, 2, or 300, 150. That's a 150. 300, that's really fast. This is a 300, 150, 100, so that's going to be fast. So we're just going to go ahead and say for fun that this is a 125 beat per minute without having to actually count the whole thing. 125 beat per minute. Regularity, as you can see the pauses down here, you can see the different changes in the regularity down here, so we're going to say it's irregular. P waves are present and married, but different morphologies. The PR interval, you can kind of see here from here to here, that's about a 0.12, that's about a 0.12, so I'm going to estimate it at 0.12 second. The QRS complex looks nice and narrow right here, so I'm going to say that's a 0.08 second. The interpretation, now what's the problem? Different morphologies. So you can't just say, oh, sinus rhythm. Now this is kind of hard to tell. Whenever you look at something like this, it might be kind of hard to tell that this is actually a multifocal atrial tach. But we have one morphology right here, which looks like this one right here. It could be that one right there. This might be kind of tough to tell. We might need to skip this one. I don't like giving really difficult rhythms for people who are just learning this because it's a little too confusing. This is really hard to tell, so why don't we go ahead and skip this one. This would, though, be a multifocal atrial tachycardia. One thing to keep in mind, though, is that if you look at the changing heights of the QRS complex right here, because you have a way upright and then you have more of a way negative down here, negative biphasic, biphasic. So this is actually what's going on here is something called electrical alternans. That's just something if you want to look up for fun. It's called electrical alternans. But let's go ahead and look at another rhythm. Maybe this next one here will be a little bit easier to identify three different morphologies. So first thing we want to do is we want to get our atrial rate. So we're going to start right here. 300, 150, 100. So that's a little bit faster than 100. 300, 150, 100, right about 100. 300, 150, 100, way faster than 100. So let's just for fun say 130 beats per minute. 130 beats per minute. Regularity, it looks to be irregular. P waves. The P waves are married. It looks like they are present and married to the QRSs. But what do we have here? We actually have different morphologies. PR interval, if we start right here and go to right here, that is right, ooh, look at that, 1, 2, 3, 4, 5. So that's right on the border of 0.20. Look over here, this one right here to here looks to be about 0.20 again. So I'm going to go ahead and say 0.20 second. What does the QRS look like? It looks nice and narrow. It looks really good. It does. It looks to be about 2, so about 0.10 second. Interpretation, we have different morphologies here, so we need to figure out why there are different morphologies. We have one morphology here, that's a down-up. This looks like an up-down, but let's look for down-ups. Let me see, do we have any more down-ups? We do. Well, I can't really tell what that is, so we'll say that that's one. Let's say that this up-down is a second morphology right here. Can't really tell if there's any more of those. This right here, I'm a little leery about using this as a morphology right here, only because of the fact that it looks like that there is baseline artifact there. So is that the morphology of the is that the morphology of the P wave, or is that artifact? I can't really tell. I'll just have to come back to it. So I'm going to go ahead and look at the next one here. That's a 3 right there. That's pretty easy to see. That might be a 3. This looks like so I'm going to say, okay, I'm going to say this one's a 4. Whoops, this will be a 4. So we have at least 3 different morphologies. So I'm going to say, but what is the other problem here? We have a heart rate that's over 100. So I'm going to say this isn't a wandering atrial pacer, this is a multifocal atrial tachycardia. Let's go ahead and take a look here. Let's see, we have an atrial rate that starts here. So this is 300, 150, a little faster than 100. 300, 150, so that's like 150. 300, 150, 175. So we're going to average it and say maybe 115, just to throw a number up there. Like I said, if I were doing this for real on a piece of paper, I'd be taking a lot more time to do this, because these are estimations. Regularity, it is irregular. The P wave, there is a P wave in here, because if you look right here where this T wave is, this T wave actually has an extra notch. This T wave does not. So this tells me that there's an extra something in here, probably a P wave. Same thing right here. This T wave looks different than this T wave. So I'm betting that this right here is a P wave. So I'm going to say that the P waves are present and they're married to the QRSs. But they are different morphologies. PR interval, it's kind of tough to tell on some of these. This one looks to be about ooh, that looks actually a little bit long. This one here also looks, let me see, 1, 2, 3, 4, 5. So that's right at 0.20. That looks to be, so we're going to go ahead and say the PR interval is 0.20 second. If you did this with calipers and you came out to greater than 0.20 second, that's just something different that we'll talk about in a much later presentation. The QRS complex looks to be about 0.08 second. The interpretation, what are the problems with all of this stuff up here? Well, we have different morphologies and we have a heart rate that is over 100 beats a minute. So now we have to, so we know it's some kind of tachycardia. So now let's look at the different morphologies. Let's look here. We have an up-down, which looks weird. So we're going to call that a 1. Do we have that same P wave anywhere else in here? I'm going to say no. Looks like we have an inverted P wave right here. So we're going to call that 2. Do we have any other 2s in here? I'm going to say no. If you look over here and see this P wave buried in the in the T wave right here, what is this morphology? I don't know. That's the problem. So let's go ahead and skip that one and come back to it. This is a 3. That's your third different morphology. Let's see if we can find another one. This one, we have no idea, so we're going to have to eliminate or consider not using it for now. So that's 1 right there, or that's a 3 right there. That looks like a 3. Can't really tell what that is. No idea what that is, because that's buried in the T wave. That might be a 3. Do we want to call it a 3? Yeah, we will for fun. We have 3 different morphologies, so we know that even if this is a 4 right here, because that might actually be a 3 also, but if we call any of these anything else, then we know we have at least 3 different morphologies of P waves. So we have 3 different morphologies of P waves, and we have a heart rate greater than 115 or greater than 100 beats a minute, which makes it a multifocal atrial tach. This one's a little bit more difficult, and I'm not going to take the time to diagnose this one, and I'll tell you why. This one you would expect to find on a patient that it would be difficult to determine if this is atrial fib or multifocal atrial tachycardia. And if you're learning this for the first time, I don't like to give really difficult strips because you can't learn how to do this properly by looking at really difficult strip that, to be honest, there are probably a lot of veterans that would not be able to interpret this very accurately just by looking at this strip. A lot of people would look at this and immediately say atrial fibrillation. But the arrows that you see here, right here, these arrows, that's actually pointed at the buried P waves. The key to take away from this rhythm strip is anytime you have a rhythm that is not a normal sinus rhythm, whether it's a prolonged PR interval, an atrial fib, a wide QRS complex, any problem outside of a normal sinus rhythm, you should really seriously consider getting an EKG. And if you got an EKG in this, maybe you would see that this is not really atrial fib, but a multifocal atrial tach. So just know that this is an MAT. You can go through it if you want and see if you could identify all the stuff. If you're more than welcome to, but if you're just learning how to do this, this rhythm strip might seem a little overwhelming. So let's go ahead and move on. So as we look at this right here, let's start off with our atrial rate. So right here, and we go 300, so that's a little fast. We have a right here, 300, 150. So we're looking at 150 here. 300, 150, 100, a little bit slower. So we'll just go ahead and say for fun this is like a 140 because it does look a little fast. Regularity is going to be irregular. P waves, they are present, as you can see, and they are married to the QRSs. If you look down here, there's a P wave buried in this T wave. Why? Because this is a normal T wave right here for this rhythm. Does this T wave look like this one? No, because that's a P wave. Does that T wave right there look like this one? No, because there's a T wave. I'm sorry, there's a P wave buried in there somewhere. This is what a normal T wave should look like. So if you have a different morphology of the T wave here, then there's probably a P wave buried in there. And if you look across the strip, there are P waves throughout the entire strip. So they are present and married. But we have different morphologies. The PR interval itself, let me see if I can find a good one here, starts here, ends here. That's a 1, 2, 3, 4. Starts here, ends here. That's a 1, 2, 3. So we'll say like 0.12 second. It's probably a range between 0.12 and 0.16 second, but I'm just going to put that down for now. QRS complex. Is there any problem with the QRS complex? There really isn't. They're nice and narrow, steeply angled, sharply pointed, everything that they need to be. So I'm going to say it's a 0.08 second. So now you have to identify what part of this is not correct, is not where it should be. Well, you have different morphologies and you have excessive heart rates that go over 100 beats a minute. So we know it's a tachycardia. Let's look at our different morphologies of the P waves themselves. So we look over here and we start with, this is a number 1. I can't tell because that's buried right there. This might be a number 1. That might be a number 1. I'm not really sure. Can't tell because that's buried right there. That might be a number 1. So this might be a different morphology here. It's kind of hard to tell because it's buried in the QRS. This is a clearly different morphology right here than that one. So do we have any more 1s? Hard to tell. That might be a 1 right here. So let's go ahead and look at this one. Let's look at this as being a 2. We don't have any more that look like that right there. So this one might be a 3 right here because it's completely different, which would actually make this a 3. So let's go ahead and change this to a 3. And this one here looks like a 3 because those two here definitely look different than this one right here. So I'm going to call that a different one right here. This might be a 3 right here, but it's kind of hard to tell. There's a buried one in here. Know what that is? No idea what that is. So here we finally have our 3 different morphologies. So I'm going to go ahead and look at this and say this is a different morphologies with a fast heart rate is going to be a multifocal atrial tachycardia. All right, last one here. Let's look at the atrial rates. Kind of tough to tell, so let's start with this one right here. 300, 150, 100, so it's a little faster than 100. Can't really tell there. Let's start right here. 300, 150, 100, a little faster than 100. Right here, 300, 150, 100. So we'll say like 110. This one over here, 110 beats per minute. Regularity, just by glancing at it, it looks irregular. P waves, this is a normal T wave right here. This one isn't, so it looks like there might be another T wave or a P wave buried in there. This, I'm not really sure why it's doing that. That looks different. That looks like a normal T wave. That looks like a normal-ish T wave. So it looks like that we have P waves that are before every single QRS complex. So we're going to say the P waves are present and married, but different morphologies. PR intervals might be kind of hard to tell here with all the different P waves, but let's start with this one right here. That looks to be about a 0.16. This here looks to be actually 0.12. So it's varying. It's a variable. That looks borderline almost like a 0.20. So we'll say what you can do here is you can put a PR interval 0.12 to 0.20 second and then say it's a variable, because there's no pattern to it. And we'll talk about that when we get to heart blocks, how that's different. The QRS complex looks to be the same across those strips, so we're going to say from here to here is a 0.12. And the interpretation. So let's look up here and see what we have. First of all, we have heart rates that are over 100, so we know whatever we're going to have, it's going to be a tachycardia. And we have different morphologies. This is irregular, which would make sense once we get down to our interpretation, but we also have different morphologies. So let's try to count all the different morphologies here. That's humped, so it looks like that's 1. Let's see if I find another humping. There's another humping. Whoops. So that's also supposed to be a 1. That might be a humping right there. It's kind of a small humping, but I'm not really sure. This one here looks like it might be humping a little bit, but I'm not really sure. So let's go ahead and move on to the next one. This here, not really sure what that is, but we're going to call that a 2 because that looks like an inverted P wave almost. Let me see if we have another one of those on here. Oh, there's another one. There's a 2. This might be a 3, but that also might be a 1. It's kind of hard to tell. But I know for a fact that that's a third morphology right there. That peaking like that, that's definitely a third morphology. So it's kind of hard to tell with this one. These might be different. These might be the same as the number 1s. But I do have at least 3 different morphologies, and it's irregular, and it's a tachycardia, so it's a multifocal atrial tach. The next rhythm we're going to talk about is something called atrial tachycardia. A lot of times this is also called an ectopic atrial tachycardia, also EAT, which just looks weird. But it's an ectopic atrial tachycardia because the atrial tachycardia usually means that it is an ectopic focus that is causing the atrial tachycardia. It is not coming from the SA node. It is usually coming from an ectopic focus somewhere in the atria outside of the SA node. So you have an ectopic focus in the atria that beats so fast that it actually takes over and overrides the SA node. So now the SA node, even though it might be trying to depolarize, this ectopic atrial tachycardia, this ectopic focus is depolarizing so quickly and sending out these waves of depolarization that the SA node keeps getting depolarized. So the SA node cannot take over as the primary pacemaker of the heart. Now, atrial tachycardias can be classified into either sustained ATAC or paroxysmal ATAC. A sustained means that it's been there and it's continuing. Paroxysmal either means you witness the onset or you can say you witness the termination. Of the rhythm. It's considered paroxysmal. It comes and goes, basically, is what that means. So the characteristics of an atrial tachycardia, first of all, the rate itself is usually over 150 beats a minute. And it could go up to about 250 beats a minute. There is some new literature out there which kind of throws us off a little bit. It says that anything over 140 might be considered an ATAC, but right now I'm going to go ahead and stick with the 150, and I'll talk about the whole 140 versus 150 thing in a different presentation later on. The regularity for an atrial tach is usually very regular, which means the ATAC itself is going to be regular, or the rhythm before or after it if it's paroxysmal. Now, if you have a rhythm strip where you have a bunch of sinus beats and then it's paroxysmal into an ATAC, this right here would not be regular because these R to R intervals would not match these R to R intervals. So this would be irregular. But the ATAC itself is supposed to be regular. The P waves are going to be present. That's how you can tell it's an atrial tachycardia, because there are identifiable P waves that are present. But these P waves are going to be different than the underlying SA node rhythm. The P to QRS ratio, you're still going to have one P wave for every QRS, and they are going to be married. Which means, even though these P waves are clipping along above 150, they are present, and even though they are a different morphology than the sinus rhythm P waves, they're still causing the QRS complex. Usually the PR intervals are going to be, they could be normal PR intervals, although they're probably not. They're probably shortened PR intervals, and they could also be variable. Once again, since this is an atrial problem, there is no issue with the QRS complex or the ventricles, so the QRSs, they could be normal or they could be wide. They could be either one. But like I said, it's an atrial problem, not a ventricular problem. So let's look at an example of an atrial tachycardia. As you can see, I got this out of a McGraw-Hill book because it was the best one I could find. As you see here, the atrial rate is between 150 and 250, and if you count out the QRSs here, you start here, 300, 150. So we'll say that this is over 150 right now. As you can see, there are P waves here. This is what makes this an atrial tachycardia. You have to have identifiable P waves. If you do not have identifiable P waves in this rhythm, it is not atrial tachycardia. You have to know that. If you do not see identifiable P waves, it is not atrial tachycardia. But in this case, you have a P wave, you have a nice T wave, and then you have a P wave, and then you go into your QRS complex. That is what would make this an atrial tachycardia. Some causes of atrial tach are myocardial infarction. This is a Wolff-Parkinson-White syndrome, and this is actually a re-entry problem that occurs. Cor pulmonale is another thing. You can look that up. Dig toxicity, hyperthyroidism, and that's pretty simple. You can look that up too. These are some common causes of an atrial tach. So let's identify a couple of these rhythms right quick. First of all, let's find our rate. Here's where we start right here, 300, 150, and it's above 150. Let's start right here. 300, 150, it's above 150. So we're going to go ahead just for fun. Let's say that it's a 170 heart rate. just for fun. The P waves are married to the QRSs down here. There's one P wave for every QRS, so we're going to say that's a 170 beats per minute. The regularity, if you get out your calipers, I'm betting that it's going to be regular. The P waves, now if I were looking at this rhythm, I would definitely do a 12 lead first of all because it's not a normal sinus rhythm. But what they did for us is they actually identified the P waves. The T wave, this is your T wave right here, and then your P wave is this little biphasic thing. You can't really identify that all that well in lead 2, but I bet if you did a 12 lead, there is another lead in there, like maybe V1 or V2, where you could definitely identify the P wave. So we're going to go ahead and say the P wave is present and married. The PR interval is going to be shortened. It starts here, ends here. It looks like 1, 2. So the PR interval is actually going to be 0.10 second in this case. And what this tells me is this ectopic atrial tachycardia is occurring closer to the AV node. The QRS complexes, is there a problem with the QRS? No, it actually looks good. There's a little problem with the T wave right here, but that could be something that you'd have to do a 12 lead for, and we could discuss that later. But what you do have right here is a very nice, narrow, steeply angled, sharply pointed QRS complex. So we'll say the QRS is 0.10. It's supposed to be a 0, not a 6. 0.10 second as well. So what's the problem that we have here? Almost everything is fine except for the PR interval is shortened and the heart rate is over 170. But we do have P waves. So we're going to say that this is an ectopic ATAC, atrial tachycardia. Here's another one here. I'm not going to take the time to diagnose this one because this is another difficult one, of course, that if you don't realize that this is a P wave, if you don't have the ability to do a 12 lead, here's your P wave right here. It's an inverted P wave. This right here is actually the back of the T wave. And then there's your P wave. It would be really difficult to tell that. But if you look at the rate, here's if you start here, 300, 150, it looks like to be just over 150. So if the heart rate were 160 beats per minute, it all looks the same all the way across, but you do have an inverted P wave. So this would also be an ectopic atrial tach. But let's go ahead and move on to something different. And there are some better rhythm strips out there. Unfortunately, I didn't have a whole bunch of them. So let's talk about something else right now. Hopefully that makes sense with the ectopic atrial tachycardia. Feel free to contact me if you're a little unclear about that, but I want to talk about something else right now. One thing I want to talk about is something called supraventricular tachycardia. And there are a lot of people out there, especially a lot of old-timers, that you'll hear this term a lot. Oh, well, it's SVT. It's SVT. I'm going to back up one slide right quick. A lot of people would look at this and automatically classify this as SVT. Why? Because it looks narrow. We'll pretend that it's narrow and it's fast, therefore it's SVT. The problem here is that SVT is not a rhythm. SVT is a group of rhythms. It is an umbrella term. It is not a specific rhythm. So you can't say, oh, well, the patient went into SVT, because there are actually 7 different supraventricular tachycardia rhythms. If you think about breaking this down, what happens is supra means above, right? Ventricular, hopefully you know what that is. Any rhythm that is tachycardic is greater than 100 beats per minute. Any rhythm, think about it. VTAC, slow VTAC is over 100 beats a minute. VTAC is over 100 beats a minute, so it's over 300 or 250. And then you have junctional tach, which is a junctional rhythm that's over 100. You have sinus tach, which is sinus rhythm that's over 100. You have multifocal atrial tach, which is a wandering atrial pacer that's over 100 beats a minute. Anything that's over 100 beats a minute is considered a tachycardia. So when you think about it, anything that originates above the ventricles is considered supraventricular tachycardia. So what are some rhythms that you might actually see that are classified as SVT? Well, first of all, I like to do the narrow complex tachycardias because a lot of people see narrow complex tachycardias as SVT, and that's automatically classified as that. And this is what American Heart says. American Heart says that there are 7 different narrow complex tachycardias, and this is their order of frequency. This is the order of how often you actually see these. The number one supraventricular tachycardia that you will have is sinus tach. If you look at the definition of a supraventricular tachycardia, it is above the ventricles, over 100 beats a minute. Sinus tach is the most common SVT rhythm. So when people say stuff like, they're an SVT, okay, well technically sinus tach is an SVT, but would you treat sinus tach the same way that you would an atrial tach that's unstable? And of course you wouldn't. The second most common supraventricular tachycardia rhythm is atrial fibrillation. The third most common is atrial flutter. We'll go number 4 is something called AV node reentry, tachycardia. This is also called AVNRT. We'll talk about that one here in the junctional presentation, AVNRTs. Number 5 is ATAC, and we just covered ATAC. The 6th most common is something called multifocal atrial tachycardia. And the least common SVT rhythm that you would run into is junctional tach. So when you have somebody who says they're an SVT, what they're saying is that they could be in one of these 7 rhythms. Now, the interesting thing about this is that you don't treat all these rhythms the same. Sometimes you might have heard somebody say they're an SVT, so you give them a medication called adenosine or Adenocard. You might have heard that in the past. Guess what? Adenosine works on this rhythm right there. And that's it. That is the number one rhythm that adenosine was really designed to try to terminate. The problem is if you give adenosine to an atrial fib or an atrial flutter, nothing's going to happen. You have to give this person like calcium channel blockers or beta blockers or some other medication to try to terminate that. But you have people that say all SVTs are treated the exact same way, and that's not true. Once you identify the underlying rhythm, which could be any of these 7 right here, once you identify one of these as the underlying rhythm of your SVT, then you have to treat the rhythm appropriately. You can't just keep calling it SVT. You have to identify what the rhythm is. So let's look at the characteristics of this SVT rhythm right here. And a lot of times in my school, I don't let people call rhythms SVT anymore. They are not allowed to call SVTs. If it is an unidentifiable narrow complex tachycardia, that is exactly what it is. It is a narrow complex tachycardia because of the negative publicity that SVT has gotten over the years. I don't like people calling it SVT anymore. It's an antiquated term. We should move away from it. It's a narrow complex tachycardia. That helps you get ready for it's one of those 7 rhythms once you identify it. So let's talk about the characteristics of any kind of narrow complex tachycardia. Normally, whenever we start off with the normally when we start out with the heart rate, it is greater than 150 beats per minute, and there's actually literature out there that is saying you should consider greater than 140 beats per minute. You should consider it being a supraventricular tachycardia of some kind, a narrow complex tachycardia. Now, what happens if you have somebody who is at a heart rate of 140, and let's say they're working out on a treadmill, or they're exercising, or something along those lines? It is very possible that that could be a sinus tach at 140 because of the sympathetic stimulation causing the heart rate to go up over 140. Now, if you're just sitting there minding your own business and your heart rate kicks up to 150, 160, okay, that's not normal. There's no sympathetic stimulation there. That's bad. That would be considered a pathologic narrow complex tachycardia. You're running on a treadmill and your heart rate's 150. Okay, that's a physiologic tachycardia. Let's move on. Regularity. Normally, this is going to be regular. But it is possible that it could be irregular. The problem is that a lot of times the faster it gets, the more regular it's going to look, even if it's an irregular rhythm. Like, for example, atrial fib. Atrial fib is never regular except by coincidence. But if you have an atrial fib that's depolarizing, that has a rapid ventricular conduction, a rapid ventricular rate at like 160 or 170, your AFib might look regular. So it could be regular, but it could also be irregular. P waves, well, it depends on what you're looking at. It could be present, or they could not be present. See, this is the problem with this SVT term. It could be present, they could be absent. We don't really know because there's one of 7 rhythms it could be. If it's a sinus tach or an atrial tach, they're going to be present. If it's an AFib or an A-flutter with a rapid ventricular response, there's not going to be a P wave. The P to QRS ratio, well, a lot of times it's indeterminate. Or it could be a 1-to-1. It's really tough to tell depending on the rhythm. PR intervals, a lot of times the PR intervals will be variable if there is a P wave, or they could be indeterminate if there's no P waves. The QRS width, most of the time the QRS width is narrow. But it is possible that you could have somebody that has a wide QRS. And what's interesting about this is that you could have a rhythm that has a wide QRS, and as soon as you terminate the supraventricular tachycardia or the narrow complex or the wide complex tachycardia, as soon as you terminate that, your wide QRS goes back to normal. It's a little bit more complicated, as you can tell. So this would be an example of supraventricular tachycardia, and I have a bunch of rhythms that I could have showed you, but I'm just going to show you this one right here. I want everybody to understand that supraventricular tachycardia is an umbrella term for a group of rhythms. It is not a specific rhythm. So in this case, I wouldn't call this SVT. I would actually call this narrow complex tachycardia. Are these P waves? Are these part of the T waves? Are there P waves buried in here? Is the P wave buried in here? I don't know. So if the patient were unstable, I would definitely start treating the patient immediately. If the patient were stable and we had a little bit of time, I would do a 12 lead on this person. I have done 12 leads on people who have been stable with a heart rate of 180 or 190, and I've seen that this is not actually this SVT. It's actually been a specific AV nodal reentry phenomenon that I know how to terminate. Or I've identified this as this is a rapid flutter or a rapid fib. Giving this person adenosine would be like, shooting a BB gun at a freight train. It's not going to change anything. But if you look at this and you see this, ideally you'd want to identify this as a narrow complex tachycardia. I would like us to do away with this term completely, but there's still a lot of people out there that still use this term. I hope you enjoyed the presentation here of wandering atrial pacers, multifocal atrial tachycardias. We also covered ATAC, and we also talked a little bit about the SVTs. The next presentation is going to cover the atrial flutter and atrial fibrillations. Those two are going to have their own presentation because there could be a lot of information about those two right there. Thank you.